the study that we carried out in Mbarara to describe the efficacy of inhaled nitric oxide as adjunctive therapy for cerebral malaria in children. So as a background, we all know that mortality from cerebral malaria in particular remains quite high, unacceptably high, and among many reasons. So we know that one of the reasons of this is that most of the drugs so far target the parasite, while we know very well from science that a lot of the pathogenesis of severe malaria actually results from your own body reacting to the parasite. And for this reason, there are very many molecules that are being targeted to tackle the immunity. Nitric oxide is one of these molecules, and evidence shows that actually the nitric oxide molecule helps to maintain the integrity of the endothelium of the blood vessels, therefore preventing leakage of fluid in the brain. Studies have also shown that nitric oxide plays a role in downregulating our immune system so that the body does not overreact. We know that nitric oxide has been used extensively in the past for other conditions, including persistent pulmonary hypertension in newborns and even in adults, and has shown it has been used safely. Systemic and inhaled nitric oxide also has been shown in preclinical studies to improve outcome, especially in research-induced malaria in animals. With this in mind, we set out with the objective of evaluating the safety and efficacy of 80 parts per million of inhaled nitric oxide as adjunctive therapy to intravenous treatment in treatment of pediatric cerebral malaria. It was an open-label, placebo-controlled randomized clinical trial, phase 2, among children aged 2 months to 12 years. Our primary endpoint was to detect the difference in blood levels of angiopoietin-1 between inclusion and after 48 hours of treatment. Angiopoietin-1 is a proxy indicator of the integrity of the endothelium. We targeted a sample size of 92 children to detect the difference between the two groups. The study was carried out on the pediatric ward in Mbarara in Uganda. The secondary endpoints were both laboratory and clinical. The laboratory endpoints were angiopoietin-2 and angiopoietin-2 ratio, and we expected the angiopoietin-2 to reduce as the disease severity improved, while angiopoietin-1 should increase. The others were several immune indicators, including interleukin-1, interleukin-6, and tumor necrosis factor. The clinical endpoints were those intended to measure improvement in disease severity, and they included mortality at 48 hours, recovery from coma, and occurrence of neurological sequelae at 1 month, 3 months, and 6 months after treatment. The child had to be aged 2 months to 12 years and to weigh 5 to 20 kilograms, really for ease of administration of the drug. And of course, they had to have cerebral malaria, as defined by presence of P. falciparum on the blood slide. They had to be in coma, and of course, lack of other causes of coma. When a child reported, they were of course resuscitated and stabilized, and thereafter enrolled in the study. Blood samples were taken off for studies, and most of the lab tests were done in the Epicentre lab in Mbarara. Thereafter, the children were monitored every 6 hours until they woke up, and thereafter once daily until time of discharge. After discharge, we followed up the children for 6 months, 1 month, 3 months, and 6 months to be able to detect neurological sequelae. The investigation product was inhaled nitric oxide, INO max in particular. It came in those cylinders, as you can see, and we delivered 80 parts per million in nitrogen or air, and they were delivered by INO pulse device using nasal prongs. The placebo was compressed air. The drugs were administered for a minimum of 24 hours if the patient woke up earlier. If the patient stayed in coma longer, then we gave the drugs for a maximum of 5 days. Of course, the children received standard treatment, including parenteral artesunate, which is the primary medication for severe malaria. The other treatments depended on how ill the child was and the presentation, and these included blood transfusion for those who were anemic, anticonvulsants if they had seizures, antibiotics, fluids, and additional oxygen for the hypoxemic. The study was approved by 4 ethical committees from different countries that were participating. And now the results. So this was the patient flow. Out of the 360 children who were eligible, we enrolled only 92. 268 children fell out because either they did not fulfill criteria or they refused, but it's important to note that 16 children died before they could be enrolled. Of the 92 who were enrolled, 46 were randomized in each arm. Eventually, we analyzed 43 in the placebo arm and 41 in the protocol arm per protocol, and those were excluded because most of them died before minimum exposure of 24 hours. The baseline characteristics were similar in all groups. It's important for us to note that children were of a younger age group, below 5 years, and that their oxygen sats were normal, or at least were brought to normal before enrollment. They were all very sick, as evidenced by deep coma, seizures in almost all of them, heavy parasthemia. For our primary endpoint, which was angiopoietin 1, as you can see in the box highlighted red, the change. So even if the change, the increase was higher in the nitric oxide arm, the difference was not of statistical significance. The same applies for the angiopoietin 2 over angiopoietin 1 ratio. There was no statistical difference between the two groups. For the other cytokines, I will not show them because similarly, there was no statistical difference in the two arms. As far as the clinical outcomes are concerned...
Vous avez 2 minutes. Il vous reste 2 minutes. Accélérez.
2 minutes left.
Outcomes are concerned, there was still no difference, as even if a little bit more children died in the placebo, there was no difference. So time to resolve from coma also was the same. Most kids woke up by 76 hours, but there was no difference in the two arms. So to conclude, we note that inhaled nitric oxide as adjunctive treatment for cerebral malaria for a minimum of 48 hours did not result in greater increase in plasma angioin, and that the clinical outcomes were the same in both arms. We also note that it was safe to administer inhaled nitric oxide. I have just 2 points for discussion. So based on all indicators, we see that there was no efficacy, but we know that it was safe to deliver nitric oxide in low-resource settings. And I leave this to the House to discuss. My duty was to present the results that we had. Thank you very much.